I'd like to introduce our discussion participants, starting with moderator Maiken Scott. Maiken is the host and executive producer of WHYY's health and science radio show, The Pulse. The Pulse explores stories about the people and places at the heart of health and science. It's heard on over 130 public radio stations every week, and the podcast is available on all audio platforms. You've been introduced to today's panelists through the film, but I'll quickly provide a bit more information about each before I turn things over to Maiken. Dr. Joel Gaydos is a retired Army physician who has worked as a civilian for the Department of Defense and the U.S. Army. His former positions include serving on the Army staff, heading the Army's epidemiological consultation service, and being science advisor for the Department of Defense Global Emerging Infections Surveillance and Response System. He is an adjunct professor at the Uniformed Services University of the Health Sciences. Dr. Caitlin Rivers is an associate professor at the Johns Hopkins Bloomberg School of Public Health and the director of the Center for Outbreak Response Innovation. She is the author of Crisis Averted, The Hidden Science of Fighting Outbreaks, which includes the story of the military's experience with the adenovirus vaccine. Her writing has also been published in outlets such as The Washington Post, Wall Street Journal, The New York Times, and USA Today. Dr. Katherine Wells is director of the Lubbock Public Health District. She has built innovative models bridging public health and healthcare, including the Intermediary Care Clinic, which provided over $100,000 in charity care to 50 patients in its first 6 months. Previously, she directed statewide and regional programs at the Texas Department of State Health Services, where she developed the State Pharmacy Assistance Program for people living with HIV. Dr. Wells serves on the board of the National Association of County and City Health Officials, more commonly referred to as NACHO, and is past president of the Texas Association of City and County Health Officials. Dr. Paul Offit is an ardent fan of the Philadelphia Eagles, even this week. Oh, wait. Sorry, that's not this panel. He's on this panel because he's the director of the Vaccine Education Center and a professor of pediatrics in the Division of Infectious Diseases at Children's Hospital of Philadelphia. He is the Maurice R. Hilleman Professor of Vaccinology at the Perelman School of Medicine at the University of Pennsylvania. Dr. Offit is an internationally recognized expert in the fields of virology and immunology. He is the recipient of many awards, including the J. Edmund Bradley Prize for Excellence in Pediatrics from the University of Maryland School of Medical School, the Research Career Development Award from the National Institutes of Health, and the Sabin Vaccine Institute Gold Medal. Dr. Offit has published more than 160 papers in medical and scientific journals and is the author of 11 medical narratives that have received numerous accolades. He is also the co-inventor of the rotavirus vaccine, RotaTeq. Rayne Mitchell is the director of the film you just saw, Forgetting to Remember, Lessons from a Vaccine Lost. Mr. Mitchell is a co-founder of Medical History Pictures, and he co-wrote and directed the feature documentary film, Hilleman, A Perilous Quest to Save the World's Children. The Hilleman film has been screened at the Smithsonian's National Museum of American History in Washington, D.C., and it has garnered several international awards. Mr. Mitchell has worked closely with the Vaccine Education Center to develop the Vaccine Makers Project, a K-12 curriculum-based initiative designed to educate the next generation of parents about the immune system, infectious diseases, and the science of vaccines. Currently, Mr. Mitchell is developing a dramatic feature-length film about the smallpox eradication effort based on Dr. Bill Fahey's book, House on Fire. And now I'll ask our panelists to unmute their mics if they haven't done so already, and I'll turn things over to Maiken.
Thank you so much, Charlotte, and thank you all for being here. And it was great to watch the film with all of you. And I guess best thing would be for all of us to stay muted, and I will call on you individually because otherwise we'll probably get a lot of feedback. And also, if our audience has any questions, we will be taking those questions. They are being sent to me in a document, so I will fold those into our conversation. So Donald, I figured since you made the film, we would start with you. And the story is as important as it is surprising in that I feel like a lot of us have not heard about this, right? This is one of those stories that really hasn't gotten as much attention as it probably deserves, especially right now. Was that part of the reason why you wanted to tell it?
Unmuting, thank you.
Yes.
Sorry. Well, first of all, I'll just let me just throw a big kudos to Caitlin Rivers, because she's really the one that that made us aware of this story in her book Crisis Averted.
Yeah.
And it was Charlotte Moser that sort of keyed in on that and said, like, hey, this is a pretty interesting story, especially in the context of where we are today. And so that's really what inspired us to move forward with this film, was the idea that it was not only a cautionary tale for today, but it could certainly be reflective of where we may be heading with regard to our vaccine policy.
Yeah. And Caitlin, how did you come across this story, and talk a little bit about what fascinated you with this?
Yeah, thanks. After graduate school, I went to work for the US Army. I was a civilian epidemiologist, and I ran the acute respiratory disease surveillance program. So I was in charge of monitoring respiratory disease in the military, in the Army specifically. And that's where I met Dr. Gaydos, who was working there as well. And it was through that job as an epidemiologist that I came to know this story. And it really, for me, gave such an important window into not just a public health issue, but such an intersection with the way that we interact with public health now. I think it's really the perfect example of panic and neglect, where you achieve some wonderful success, enjoy the fruits of that success, and that period of calm invites complacency, which then, of course, rolls back the protections that facilitated such triumph. So, for me, was a really important window into a dynamic that we see a lot in public health.
Mm-hmm. And Dr. Gaydos, it's also a bit surprising because from everybody I know who's ever served in the armed forces, they always talk about how many shots they've gotten, right? And how many shots and how many precautions. And it seems like usually the armed services really tend to err on the side of caution given the stakes. So talk a little bit about this story and why perhaps it's different from the usual story within the military.
I think the military problem with the adenovirus vaccine occurred because of several reasons. Initially, it was because the letters from Wyeth got lost in the military bureaucracy. They went to staff officers. Staff officers did what they thought they were supposed to do, which was to put a line item in the military budget. They failed to elevate that problem up to the level of professional people who knew the seriousness of the consequences of losing that vaccine. And they put the line item in, but it didn't go in with strong advocacy, which it would have had if the people who knew the consequences were involved. And so it was rejected. Then when we started to brief people, we found that we had very high-level people who were not aware of the seriousness of the consequences. We had one high-level individual who viewed the vaccine as a vaccine for a cold. And then when we started briefing other people and presenting them current data at the time, looking at what was happening and what the consequences were, we encountered a culture of management that was very prevalent and still persists today. And that culture of management had these high-level people looking at their terms of office. So their terms of office were 2, 3, maybe 4 years. And so their scope, their horizon, for the problems that they wanted to put on their desk and solve were the problems that they could deal with in that period of time. And I think they viewed this as an expensive and really long-term problem. And so they were reluctant to take it on. And with the management structure at the time, which very much was like silos, there was not a strong feeling from someone who was looking over the entire military to say, my gosh, this is a really serious problem and we need to take it on. And I think the problem persisted in that management environment until it reached the point where it was in a major newspaper. The National Academies of Sciences was writing to the DOD saying this was not acceptable. And someone finally felt in their heart, this cannot be kicked down the road anymore.
Dr. Offit, what's your immediate reaction to this film? Obviously, this is a topic that you've worked on for decades now.
I think it's painfully relevant. What scares me the most about what's going on right now, and this just in the last couple of days, there was a personal injury lawyer who works closely with Robert F. Kennedy Jr. named Aaron Siri, who put out a missive, I don't know if you've seen it, that says basically they are going to start taking vaccines off the Vaccine Injury Compensation Program schedule and basically let them see how they do and under the slings and arrows of civil litigation. And then we're right back to where we were in the 1980s. We went from 18 companies that made vaccines to 4 by the end of the decade. And I don't think people realize how fragile this market is. I mean, Caitlin did a wonderful job of explaining how fragile this market is. It is sort of a complacency. You assume you're going to have these vaccines, but these companies were perfectly willing to abandon the vaccines in the 80s, and I think they're perfectly willing to abandon them now if you make it burdensome enough. That one scene where the Wyeth representative came and sort of threw things on the table and said, "Look, this is what I've been trying to do." The point being, it is burdensome, and I think that and they're not big market products. They're not going to ever compete with lipid lowering agents and diabetes drugs and other sort of recreational drugs. So I think, or lifestyle products. So I think that I don't think people realize that. I don't think they realize that. I feel like we're falling off a cliff in slow motion, and this film showed me just how bad things can get.
Yes, and I think we have Dr. Wells, you're with us now. So yes, talk a little bit about this frontline situation that you experienced. I think for a lot of us, we hear about these outbreaks on the news, but you were sort of in the middle of this. So talk a little bit about that experience and the burden that puts on the system.
Yeah, I mean, being in Lubbock, Texas, that measles outbreak that occurred in West Texas was really in our backyard, like I said, in the movie. We found out about those initial measles cases with 2 children hospitalized in the children's hospital in our community. We're the hub for all medical care, so people travel 100, 200 miles to come in to Lubbock for care. And that was the first time we're really seeing a measles outbreak of this size in many years. It was a huge strain on our hospital system. People talk about, measles being mild, but as Dr. Offit said, there's so many severe complications that can also happen. We had 99 individuals hospitalized, and our children's hospital was dealing with multiple children in the hospital while infectious, while also taking care of, children with cancer and other, severe medical conditions in that same facility. And we ended up with, exposures in waiting rooms. We ended up with an outbreak in a daycare, all because of the stress of having this unvaccinated population and this very large measles outbreak, happening at one time.
Caitlin, I want to talk a little bit to you about this whole paradox of, when you see a crisis like the one that you just described, Katie, it's easier to get people perhaps to react, right? But a lot of times, like your book title says, the crisis is averted and therefore it seems like all is well. what are some ways, or are there ways in which you can keep the problem visible even when you have found solutions to address it?
I do feel like storytelling is such an important way to
Mhm.
help people to understand and see what's not easily visible. And that's why I'm so honored to be joined by Dawn and Paul, who have done so much to tell the story of public health for the broader public. I think that's really helps people to look behind the curtain and see all of the benefits that public health has brought us. Absent that, it's what we don't want to be doing is constantly ringing the alarm. Nobody wants that from the public health professional side. Nobody wants that on the policymaker side. And so it's a real needle to thread. And so I think not only outlining the perils of what happens when things go wrong, but also telling the story of when things go right are they're really both powerful ways to tell the story of public health and why it's so important and so powerful.
As the cost of democracy is eternal vigilance, the cost of public health programs is also eternal vigilance. And I realized very early that all public health programs are vulnerable. People forget, attitudes change, cultures change, budgets change. And if we live in a society, and we've been in this society for many, many decades, of really looking at what is just immediately in front of us. People don't want to look too far into the future for a number of reasons. So if we don't look at our own public health programs, our own vaccine programs, and we don't look at what the threats might be, they will get lost. And I remember back in the 70s, some people came to the conclusion that our vaccination programs for polio in the United States were great, and we should stop giving polio immunizations to military people coming into service. And Dr. Don Burke was at the Walter Reed Army Institute of Research at the time, and I worked with him and a number of other people, and we were very quickly able to show that we had actually a pretty low prevalence of antibody to polio, to the polio viruses in the recruits coming in, and that these people were being assigned in places in the world where polio was prevalent. And so we were very quickly able to get onto that and to show the people the data that we had. At that time, that was the end of that proposal to eliminate polio immunization from the military vaccine schedule. So I think we need to look at these programs. We need to keep a list of these programs. We need to periodically go back and ask ourselves, what is happening with this program? How's the funding? What's the attitude out in the population that's receiving the benefits of the program? What do we know about what's happening with the people who control the purse strings that are funding this program? And that's very difficult to do when you're facing on a daily basis a large number of things, but I think it's absolutely essential.
Mm-hmm. And Donald, as you were telling this story, what were some of the big issues that really like stood out to you, where you were like, I can't believe this is how this went down?
Well, one of the things that this will maybe, I don't want it to sound crass, but one of the things that drew me to this story, when we talk about public health, of course, the first thing we talk about is health and life, right? People's lives are at stake. But this was such an interesting story from the military side of things. There was a real dollars and cents aspect to this story. And that was, as Caitlin points it out in the film, that was just so incredible that they started out with this $5 million price tag to just keep the vaccine going. And it turned into $350 million later and, 11 years afterwards. So I found that to be just fascinating because it was an exclamation point on top of the health aspect of this.
Mm-hmm. Mm-hmm. And Katie Wells, I'm wondering if, in the film we heard about the people who died because of this illness. And Paul, I think you said one preventable death is one too many, right? So on the heels of a crisis like the one your community went through, do you see people changing their minds? Do you see a new conversation emerging?
When I've had to, describe what's happening, I kind of see people in kind of three different, buckets. There's a group of parents that are very pro-vaccine and they're going to get every vaccine that's available. And there's a group that's very dug in about not getting vaccinated. I think we saw with the measles outbreak a change in that middle group. I think individuals that were, well, why do I give my child a vaccine that might hurt them? It's painful. My child will cry for a virus or a disease I've never seen. We saw that group really change that perspective, seeing actual measles cases and wanting to get vaccinated.
Mm-hmm.
And I think that's a place that we can work with, is those individuals focus the vaccine promotion efforts around that group.
And I think a lot of the undecided, you may be able to present them information and help them to make their mind up. But when you're looking at those who are opposed, I think it's important to try to get an understanding of why are they opposed? What is it? Is it something they've seen on the internet? Is it something that happened to a family member? What is their reason for being opposed? And I think once you have an appreciation for that, you have a better chance of communicating with them. And certainly getting back to the idea of talking about things in a way that people can understand, in a way of a story. I always fall back on what Ken Burns said about storytelling. You can never change a person's mind with a strong argument, but you can change their mind with a good story. And so I think that those communication skills are maybe something we ought to look at teaching in schools of public health and in medical schools. We've become so enamored with technology that we've forgotten about a lot of the things that are very important in the interpersonal relationships.
Paul Offit, let me, I guess, turn back to you. We're both in Philadelphia. We've known each other and worked with each other for a long time now. And when we started working with each other, probably about 20 years ago, the autism conversation was happening. It was a new conversation back then, and things were really heated when it came to vaccines. So did you think you would find yourself back at this kind of place again? Because it did seem like the conversation at least got a little bit more rational somewhere in the middle.
No, I didn't. I mean, we have a Secretary of Health and Human Services who is a anti-vaccine activist and science denialist. So he just keeps retreading all these things we lived through 25 years ago with whether, the combination measles, mumps, rubella vaccine caused autism, or whether thimerosal and ethyl mercury containing preservative vaccines cause autism. And now, he offers things like avoid Tylenol in the first trimester of pregnancy to avoid autism. It's just big, this onslaught against science. I mean, he declares his own truths, including scientific truths. And I only hope we can get through all this, because I think it's only going to get worse and worse. It's amazing how within 1 year, how much damage he has done to the vaccine infrastructure in this country. And I keep waiting for someone to stand up, for the children in this country, and everybody who's in power stands back. There's this wonderful documentary in 2010 called Waiting for Superman. It's really well done. It's narrated by a guy named Gregory Canada, who talks about, it's really an indictment of kind of the public school system, especially the charter school system. But he talks about when he was a little boy in reduced circumstances, he kept waiting for Superman to come save him. He wanted this person who clearly had power to save him, and then how devastated he was to learn that Superman was actually a fictional character. I feel the same way about Congress. I think they're largely a fictional character right now.
And Caitlin, you mentioned the power of storytelling. Obviously, Donald, that's something you believe in as well. And a lot of times it seems like the public health perspective comes out of the defensive, right? So there is some kind of information that's out there or some misinformation, and then all of the official information is geared at dispelling the bad information. So is there a way to be, I guess, more proactive in the storytelling, in telling the story before things get off the rails? And Caitlin maybe, and then followed by Donald.
For all of the challenges that we're facing in public health right now, I think there is one bright spot, which is that there are a lot more kinds of public health professionals who are able to participate in the public conversation in a way that maybe wasn't true or didn't make sense 10 or 20 years ago. So from my perspective, having worked in governmental public health and now as a professor, it's very hard for our governmental colleagues to be forward leaning and to act ahead of rumors or to anticipate events and communicate about those. So they are often just left reacting because that's the constraint of working in the government. But we do see this proliferation of public health professionals who are working in academia or are working privately to put out high quality information. And I'm one of them, obviously, as a writer, and I have a newsletter as well. And those kinds of non-traditional forums, I think, allow for a broader range of storytelling and for doing things like getting ahead of narratives in a way that's not possible for the government. So I think they're all really important. I don't mean to elevate one above the other, but I really like that there are now these other voices that are able to participate.
Donald, do you want to weigh in on this as well?
Yeah, I think it is an incredibly interesting time because there is a platform for almost anyone to tell their story. And that's part of what has made this situation so difficult, is because it just depends on where you happen to point your ears or your eyes and what story you choose to listen to. So I think now more than ever, it's important that people that have a scientific basis to tell their story from, it's just so important for us to be out there telling those stories, because the narrative coming from official channels at this moment may not necessarily be so reliable. So, we have to have scientific voices out there.
I believe that very often those of us in science and public health and medicine tend to talk to everybody like we were talking to our colleagues at a medical meeting. And there's a big difference between transferring data and information from one colleague to another and talking to someone who doesn't have that background but has concerns that are coming in from all over the place. And I often think about the great communicators, Franklin Delano Roosevelt during World War II and Ronald Reagan. And they had mastered the art of being able to talk to a crowd, but yet they could connect with every person in that crowd on an individual basis. And they were able to project a feeling of, I care about you, and I'm really here to help you in a very sincere way. And I was watching a lot of the people who came on TV during the COVID crisis. And so many of them came on TV and they did a great job of presenting data and information. But they did it in a way that they would do it at a scientific meeting. And I think that art of presenting information to a public that's different than you and has different concerns is really an art. And I think we've lost a lot of that. And I think we need to come back and focus on that. And I believe that one of the reasons we find that communication about public health programs at the clinic level, for example, in the pediatric clinic, is effective is that does occur. That does occur between the providers and the patient's parents or the patients. And I think we need to take a look at how we might master those skills on a larger level, talking to larger populations.
So, Paul, let me turn to you. I am wondering where you see some of the major threats emerging. So obviously there is the threat of people just not getting vaccinated, not choosing vaccination for their children. Then there is the threat of vaccines being discontinued. Where do you see some of the other big problems here?
Well, I think that what I understand from speaking with pediatricians is there does seem to be a lot more pushback on vaccines. I think what Robert F. Kennedy Jr. is trying to accomplish is to make vaccines appear optional. So when he, for example, moves the rotavirus vaccine or the flu vaccine or the SARS-CoV-2 vaccine to shared clinical decision-making, what he's really saying is he's saying, you can reasonably make a decision not to get those vaccines. I mean, those viruses are all so-called short incubation period mucosal infections. They're all around. They're not going anywhere. I mean, we could eliminate measles in 2000, or we could eliminate polio in this country, by 1979, or we could eliminate smallpox by 1980. Those are long incubation period diseases. You'll never eliminate these viruses. They're always around. So a choice not to get a vaccine is a very real choice to get ill, and that's the choice that he's saying you can make. And similarly, he moves other vaccines like the meningococcal vaccine or the hepatitis B vaccine or RSV vaccine or hepatitis B vaccine to kind of just high risk groups. What is a high risk group for meningococcal disease? I mean, people who breathe, or a high risk group for hepatitis A, people who go to restaurants or eat strawberries imported from other places. I mean, it's just everybody's at risk. There's not really high risk groups there. Everybody's at risk. So he's just eroding the perception of vaccines as being something optional and sort of likening us. Why don't we more like Denmark, which only gives 10 vaccines and not the 18 or so we give here? I mean, because they're not willing to pay for those vaccines. That's why they're a national health system and they're not willing to pay. So they're willing to have the same level of hospitalizations with rotavirus or RSV that we were seeing here. They're accepting that. We don't accept that. We don't think it's okay for children to suffer or be hospitalized or to occasionally die. And Denmark stands back. Why are we emulating them when they should be emulating us? I just think, I really fear what's about to happen in this country because I just feel like we all see it. We all see what's happening, and yet nobody is standing up who can stand up to do anything about it. It's just so hard to watch. So every day, here you have, Robert F. Kennedy Jr. saying that children, might reasonably choose not to get a flu vaccine. He said better off. That some children might be better off not getting a flu vaccine in the midst of a flu epidemic where almost 300 children died last year. Another 17 have already died this year. It's like a bad Saturday Night Live skit. I just can't imagine we would ever be here where people just simply deny science.
And Katherine Wells, in terms of the strains on a health system, if a crisis like this goes on for an extended period of time, what would happen to a health system, especially in an area where so many people rely on, let's say one hospital? So talk a bit about how this could really send shockwaves through an entire system and really overwhelm the system.
I mean, with measles, the hospitals had to deal with, a virus that they hadn't had to deal with in their walls for, at least 25 years. And it's all about timing. If you end up with a measles outbreak on top of a rubella outbreak in the middle of flu season, you really start overwhelming the capacity of both, hospital beds and also, our outpatient clinics and getting people, in for care. You start overwhelming testing systems. Measles is something we shouldn't have to deal with in our healthcare system. And it's, we saw just from the cases in Gaines County and Lubbock County that, that really can add a burden to that system. It's not built right now to handle that, plus everything else.
And Caitlin, I would think it eats up precious resources that, are already scarce, that people could be spending talking about other things coming down the pike, God forbid another pandemic, or, anything else. So this is sort of like spinning a small circle around an issue that was resolved quite some time ago.
Measles is incredibly burdensome, as I'm sure Dr. Wells can attest to, and it really does take up almost all of a health department's focus when they're called to respond to a measles outbreak. And 2025 was a banner year. It was the most cases we'd seen since the 1990s. And so you're exactly right that does take away resources and funding and personnel and space from all of the other pathogens and all of the other public health issues that we want to focus on. So it really is a drain on our public health system and therefore a drain on the community.
It is extremely important that we continue to gather data, that we continue to assess our programs, that we continue to look at new pathogens, we continue to look at evolving pathogens. And I think that most people don't really appreciate the amount of work, the background work that goes into the influenza vaccine, and how on an annual basis, so many people throughout the world are collecting data and information, clinical data and information, isolating viruses, collecting serologic data, and how that amounts to a vast amount of information that then goes into the decision making. And so that is just one example of what we have been doing in the past and what we need to do in the future. And again, if there's a program and it looks like perhaps we should change a recommendation, there's, for example, in the military, there's always been that question, okay, if the civilian immunization programs are that great, do we need to continue immunizing as people come into the military? And so we need to look at all of that.
We're getting some questions in from the audience. I'm going to try to read them live, so please bear with me as I try to do that. So here's question number 1. Thank you for sharing this important movie and your perspectives. My comment question refers to the heterogeneity of the population who refuses to be vaccinated and potential strategies to approach such situations. I've been observing that the vaccine hesitant population is quite heterogeneous one, including those with religious reasons, lack of scientific knowledge, but are willing to learn and do the best for their families. There are those who think that vaccination is part of a global conspiracy, those who deny not only vaccination, but science as a whole, and those who profit from vaccine misinformation. Do you think we would be able to harmonize a common approach to communicate to such a varied audience? So who wants to tackle that? Maybe we'll start with Paul Offit.
I think there are some instructive examples. So, for example, when that 27-year-old man in Rockland County, New York, as part of a sort of ultra-Orthodox Jewish community, got polio, and when you're paralyzed by the strain of polio he was paralyzed by, it's only paralyzed about 1 in 2,000 people. So he was the tip of a much bigger iceberg. But I think what happened is that the healthcare people wanted to try and find people in that community who that community trusted, which was their religious leaders, and then give them good information to then try and make sure people got vaccinated. And vaccine rates did obviously increase. And same thing with the Somali American population in Minnesota when they had a measles outbreak. It was the public health people there, like Chris Arisman, worked with the imams, who were trusted in that community. So I think he's right that the questioner is right that it is heterogeneous, and so therefore I think it requires different strategies. One thing I didn't say before that when you were talking about things I fear, one thing I fear is that most young doctors haven't seen these diseases. I mean, we had a child in our hospital who came in with measles, and that child didn't need IV antibiotics didn't need intravenous fluids for his dehydration. He didn't need oxygen support for his pneumonia. He didn't need to be in the hospital. And, I'm looking at this thing, this measles, that's the last place you want someone with measles to be, is in the hospital if they don't have to be there, because it's that contagious. Or we had a child who had something called Haemophilus influenza B, which is a bacterial infection that typically causes bloodstream infections and meningitis, but it also causes epiglottitis, which, the epiglottis swells, it sort of blocks off the upper airway, and basically you suffocate. There was a child at another hospital who was transported to our hospital by ambulance. Last thing you want to do, because it's if his airway closes off, you don't want to do an emergency tracheostomy in the ambulance. So I feel that there's a lot of learning for our young physicians who didn't grow up with these diseases. That scares me too.
Absolutely. Anybody else want to weigh in on this question of communicating one message, but communicating it to very different groups who may have very different motivations?
Maybe just to
And
reach
also,
back to my observation that there's also, I'm sorry, Katie, that there's also a time, this is a time of a lot of different communicators on the public health side. So there can be sort of matching. I think the biggest gap that remains outstanding is matching the people who need certain information with the communicators who can provide it. But at least there is now the range of communicators. There are now options.
Mm-hmm. And Katie, do you want to weigh in as well?
yeah, I was just going to add that, the need for communication that's focused on specific groups really shows why we need, a governmental public health structure, throughout the country that of people like me in local communities that understand those communities and are building those bridges and that trust. Coming in during a measles outbreak is not the first time you should be working with that community. You should have community health workers and other members of that community already embedded within your public health and medical system to be able to spread those messages.
So long before a crisis erupts, you need to start building those bridges.
Yes.
Yeah. But again, it speaks to this issue of like now precious resources are being sucked into dealing with these ongoing crises. And then it's hard to build those bridges because you're sort of continuously in crisis mode. So let's take another question, which we've already hit on a little bit, but I think it's a really important topic to explore here. So are you concerned that if companies are willing to drop making new vaccines because the government will potentially make it too difficult, do you also have concerns that vaccines that are not new and have been made for years will eventually be dropped by these companies so they don't have to deal with the federal government or the FDA, at least from this perspective? Again, we touched on this a little bit, but I think it's an important topic to explore. What does all of this mean for the development of future vaccines and for the ones we already have? Anybody want to start on this one?
So I guess I'll start. I think, I was through my medical career included the 1980s, and I watched us go from 18 vaccine makers to 4 because we made it so burdensome for them to make those vaccines. I think mostly for civil litigation. But I think in addition to civil litigation, when you look at the kind of things I just got today from a reporter about what Martin Kulldorff and Christine Benn at the CDC are promoting for what they want to do now to sort of do these studies that frankly are wholly unethical, where you do like placebo-controlled trials for flu vaccine, knowing the flu vaccine can prevent hospitalization and death in young children, as we've shown in study after study. But that's their premise, that we need to prove these things all over again. Make it burdensome enough. And these companies believe these are not big market products. And I just don't think we kind of realize how we're right on this precipice. And I really do feel like you just want to scream. So that's why, Don, you need to go to Congress and show this movie and make that point. As a Republican caucus, that's what I would suggest.
Anybody else want to weigh in on this specific issue?
Well,
I just want to add. Oh, I'm
go
sorry.
ahead.
You go.
Go ahead.
I just wanted. You go. I'll give it a mute.
I was just going to say, I think, the part of the question was what happens when you have these older vaccines that have been around a long time that, that all of a sudden aren't appreciated anymore. And I mean, isn't that what this story is all about with the adenovirus vaccine? And it just happened to not be a vaccine that the majority of the public was privy to understanding or knowing about. But that's the worry right now, is that we've for so long now lived without some of those diseases that here we are in a place where we could easily say, what do we need that for? Caitlin?
Yeah, I think it's important to note too that for all that vaccine hesitancy is very real and growing, it also remains true that vaccines are enormously popular. Even with the measles coverage, nationwide, our coverage is about 90%, and that's below where we want it. We want it to be in the 95% zone, but there is very little in American life that can capture 90% of the population, and that we can agree is worth doing and getting. And so when we think about the loss of these vaccines, and not just choosing, but not even being able to get them, that is going to be an enormously unpopular situation. And I think it's important for policymakers to remember that the constituency that wants that to happen is very small.
All right, should we move on to the next question or
Okay,
any
Caitlin, I'm sorry, Mike, I just want to add one thing to what Caitlin just said, because I think it was really important. Most parents support vaccines, Republican, Democrat, Independent, and most parents support vaccine school entry requirements. So when I keep waiting for Superman to come save us, I think the Superman here is really parents. I would love to see them stand up as a group, as a bipartisan group, and march into their congressman's office and say, I'm scared about what's happening right now. As a voter bloc, as a bipartisan voter bloc, I think they are in the best position to save us here.
Yeah. And in a lot of ways, I think part of what we're seeing is that the loud voices of a few are really drowning out the voices of many who either are not saying anything or are not as loud as all the other noise we're hearing out there. So question number 3, we're getting from the audience. And by the way, we're getting a ton, so we'll try to speed through some of them. So now that vaccines function as identity markers for many people, is it possible to return to them to a primarily medical framework, or has that window closed? If that's still possible, what would it require? So this is a question where, whether you say yes or no to vaccines has really become part of, to some people, who they are and what they believe, right? It's not so much about this is a medical necessity. So is it possible to turn that conversation around?
Panic. What follows neglect is panic. And so when we see resurgences of preventable diseases, when we see unnecessary loss of life, severe illness, missed school days, missed days of work, those are reminders of why these vaccines are so important. And we never want to be in a position where those reminders are quite so near at hand. But if we continue down this road, that's what's coming.
Mm.
I
guess we, sorry.
I just wanted to add, I mean, and Paul says this often, but, vaccines are not a belief system. This is science. And so, you can, if it's part of your identity as to whether you're going to get a vaccine or not, I mean, that's not something that's an identity thing. It's a I'm going to save my own life and my children's lives thing. So it's not a belief system.
And if I can only add, and I completely agree with that, this didn't used to be this way. I mean, there wasn't a politics of the anti-vaccine movement. Sort of on the left, it was kind of, all things natural, don't inject me with things that are foreign. And on the right, it was what you see more now, which is this libertarian notion of government off my back. I think the COVID pandemic sort of drove things more to the right. I mean, to some extent, there's always going to be a politics to public health because it requires resources, but it never had to be partisan. But I think that's happened in many ways as a result of the pandemic. And RFK Jr. said that. He said, I'm in this position, meaning Secretary of HHS, because of COVID. And I think that's right. I think what happened during COVID really drove this more than anything else. So maybe that answers your question. As we get further and farther away from this pandemic, maybe things will get back to where they used to be, where both sides, sort of both Democrats and Republicans had their own anti-vaccine views.
Yeah. Next question here. The initial military leadership response to the loss of the adenovirus vaccine was surprising and disheartening. How might better use of health economic modeling or cost effectiveness analyses have altered the decision to discontinue the vaccine production? And how can military decision makers be reached to respond appropriately before it becomes a, quote, message to the heart? So any thought on, this kind of, we talked earlier about how the $5 million price tag ballooned into this very expensive proposition. So could this have been avoided through better cost effectiveness modeling?
Dr. Gaydos might be able to contribute to the chat if that is
Yes.
an option for you. But I could say that I see a lot of value in using modeling to help decision makers to understand possible future scenarios, and that the economic angle is one way that you might say, here's what we're looking at if we do spend, if we don't spend. I think it helps people to build intuition about possible futures and can be really valuable for that reason. But I don't think cost effectiveness or any kind of scenario model is going to be a magic bullet, because everyone has their own priorities and own ways of looking at things. And so I think being adaptable and really understanding the priorities of the audience is always going to be super important.
Mm-hmm. Anybody else want to weigh in on this one?
If I could add, and I don't, Dr. Gaydos would be able to speak to this so much better than me, but one of the things that I gathered from our work on the film was, there was at that time in the Department of Defense, there was sort of a siloing of the different decision makers that were at play here. And, I think obviously one of the lessons learned from that was that the bean counters that are trying to figure out what to spend the Department of Defense budget on, and the people that are working in public health need to be not in their silos and need to be in direct communication with one another. Because I don't think it was that the bean counters didn't want to do the right thing. I think they just didn't understand the importance of this decision. And so there were just not enough communication happening between the silos at that point in time.
After the vaccine was implemented and fielded in the early 1970s, within a couple of years, there was a cost effectiveness analysis that was done and was published and showed the benefits. And during the time that we went through the endovirus crisis into the 90s, and we did cost effectiveness analysis, economic analysis. Those were reviewed, they were peer reviewed, they were published, they were presented, and those data were up there along with the mortality data, morbidity data, and they were still rejected by the people who were receiving the briefings. When you have silos, people are always looking at, is that my budget or somebody else's budget? And so I think that unless you have somebody who has a broad overview and feels responsible for a large number of people over a long period of time going into the future, those data won't touch them, because they have that very, very limited horizon that they're working on to make their next 2 or 3 year assignments look good. And that persists today in a lot of places.
Next question here. And if anybody, Katie, if you want to weigh in, or anybody wants to weigh in, please just speak up, because I'm toggling back and forth between the different screens. So question here from an audience member: we are not failing at science, we're failing at the communication of science. Healthcare providers are trusted but not trained in communication. This is a critical mistake. Does the panel have any examples of solutions to this critical issue? So again, how do you get people? I think at some point, for example, pediatricians adopted the phrase, this is what I did with my children, if they had children. And it turned out that was like one of the very helpful and very simple messages. Or it was simple things like not saying, this vaccine, for example, with the HPV virus, this is for this, this, and this, but just saying like, here's the vaccine that's on the schedule, it does this and this, let's move on. Those kind of strategies, I think, have been really helpful to providers. What else are we learning about effective communication? Paul, do you want to start?
Sure. No, I think, so there are some things that clearly work. I mean, just as you mentioned, when a physician walks in or a nurse walks in and says, here's the vaccines that we have today, which ones do you think you might want to get? It's very different than saying, here's the vaccine that the child is getting today. I mean, just that helps. And I do think we're not trained in communicating well. Certainly as a science communicator, if you sound like a scientist, you're not going to be very believable. And so that's part of it. But what do others think?
Mm-hmm. Katie, do you
I'm
want
not
to
a.
start?
Oh yeah, Katie, that's better. Just gonna say I'm not a clinician, but I can try.
I think, I mean, the one thing, and Caitlin brought this up earlier, is that we're seeing lots of different groups coming up with how best for public health to communicate, and some really great ideas coming out of different collaborative groups nationwide. But it's going to take some time to get that down to the local physician's office, because they haven't in the past had to, encourage people to get vaccinated. It was kind of something where you said you need this vaccine and they got it. So I think over time we will see a lot of those communication tools trickle down to the private practitioners and those nurses on the front line, because that's really, who gives the vaccine, and that's who the individuals trust.
Caitlin, anything to add to this?
Just that the physicians and nurses, of course, but there's also pharmacists, there's clergy, there are school administrators, all sorts of people who have an opportunity, depending on current events or the circumstances, to help support health in their communities. And so I think taking a broad look at the kinds of messages who could help support the work of public health has been really helpful in past outbreaks and should be a lesson we carry forward.
I think that we need to look at storytellers. I mean, storytellers are usually calm. They're not rushed. They're interested. They want to tell you something that they feel is important, and they bring you in. They want, and you feel like you want to listen to them. And I've talked to many of my friends who have been watching the Ken Burns series on the American Revolution, and the response that I've gotten back from many of them, and these are people mostly with professional degrees, they said, I've really never appreciated so many of the things that series has brought out about the Revolutionary War. And so I have a much greater appreciation for the Revolutionary War. And I think that that's the same way for medicine. It's the same way for public health. We have to look at communicating. And I think it is important to study the great communicators, the great storytellers.
So let's move on to our next question from the audience. Regarding the security of vaccine production, are there laws requiring manufacturers to give a certain amount of time notice to discontinue production, like 1 or 2 years, or can they just stop production anytime? Can anybody weigh in on this? Don?
Well, I mean, I can speak to what I learned about the adenovirus itself. I don't think that there was necessarily a snap decision to stop manufacturing that vaccine. What happened in that circumstance was over the course of about a decade, there just was no response from the main customer, which was the Department of Defense, to the manufacturers. Please, help us figure out how we can continue making this product. And so it became a business decision at a certain point for the manufacturer. But I don't know whether there are laws that are in play for a manufacturer to have to announce that they're going to stop making a product.
Yeah. Okay, if anybody else wants to weigh in on this, just let me know. Other than that, I will move on to the next question. What effect on vaccine use are cutbacks in data collection and monitoring having? These are mostly below the radar, but it seems to me you can't fight something you can't see. So again, the question of if we're not monitoring different diseases as diligently as we did in the past, if we're not collecting as much information, then how does that affect the system as a whole?
I think Katie should answer that question. I mean, Katie, I think has a sense of whether or not, say, the 2,000 cases that are currently reported by CDC of measles is probably a vast underestimate of what's really happening. But she would know this better than I would.
Yeah, I mean, one good thing with public health funding is we've not seen a cut yet to the surveillance process for notifiable conditions, and every vaccine preventable disease right now is part of that notifiable conditions. So I think that capacity is still there. One of the things we did see out of the COVID pandemic was actually the development of wastewater surveillance, which is a wonderful tool to detect outbreaks, because we can actually pick up something like measles in the wastewater system of a community, and then public health knows that they need to go and target that system. So I think that part of public health, hopefully I can say is, safe or at least funded right now. And that's very core that we keep that going. We are losing, the outreach staff and the other, trusted individuals that can be out in community, and that's concerning.
Yeah.
I think dismissing the need to be vigilant and collect data and look at what's happening into the distant future, the lack of that approach is really destructive. And it will hurt us for a long period of time. Because, as we've discussed many times, it takes a long time to do good science. It takes a long time to get a good product out there. And we've been talking about vaccines, but we could extend that to other things like antibiotics. And certainly in the military, we've already experienced problems with a stable supply of penicillin. So unless we continue to collect data on how well we're doing right now and how stable our programs are right now, and project into the future and look at where our vulnerabilities are and try to address them before they become serious problems and maybe destroy a program, that's a very destructive approach, and it will hurt us for many years to come.
Next question. How can we as public health professionals penetrate the walls of Congress to get the message across to them? Do we reach out to our local senators and so on? Asking from Florida, so we have our own challenges. This is frightening. Paul, do you want to start?
When Robert F. Kennedy Jr. had his second confirmation hearing in front of the HELP Committee, Health, Education, Labor, Pension, Senator Bill Cassidy called me the day before, including the night before. We talked several times on the phone and about who he was, who RFK Jr. was, and what he likely would do. And he listened to all that. I mean, he's a doctor. He's an adult gastroenterologist. He's certainly seen the complications of hepatitis B infection, whether it's cirrhosis or liver cancer. He has been a passionate advocate for hepatitis B vaccine in his home state of Louisiana. Nonetheless, he voted yes. And now he has watched all the promises that RFK Jr. said he would make. He's broken again and again and again. And still he does nothing. And what does it take? It's just so frustrating. The thing that I don't understand actually is most parents do support vaccines. Therefore, most voters in that sense support vaccines. This is all about countering President Trump and his appointment of RFK Jr. and that they just are too cowardly to do anything about it. I don't know what it takes. I mean, there's an unnamed congressman in the state of Pennsylvania who's very much a pro-vaccine person, a Republican in a red district, very red district, who behind closed doors talks about how awful he thinks this all is, but he doesn't do anything. So why even get elected if you're just gonna, just stand back and be told what to do?
Yeah. Anybody else want to weigh in on this issue?
I mean, I think it's so important. I'm in a red state. I'm in Texas, but getting to know your elected officials, not being scared to go knock on the door and tell them your concerns about, vaccines or any other public health issue, and it's comes down to building those relationships and having conversations. One thing we try to do is invite elected officials into our public health department, so they see what we're doing both with vaccines, but what we're doing with HIV care, what we're doing with surveillance, what are we doing with substance use, letting them see the full breadth of everything that we touch as a public health department.
And again, I think it goes back to the whole idea that this is not an identity. It's not an identity question. It's a medical question. And I guess we can discuss the science, but when it becomes part of your identity, that's when the discussions really go off the rails. Caitlin, sorry, I interrupted you.
If I could just add to remind people that most public health happens at the state and local level. So when we're looking at school entry requirements, vaccine clinics that are hosted by the public health department, most public health happens at the state and local level. Now, when you think about, will FDA take vaccines off the market? Okay, yeah, that's federal. But don't overlook your local politicians when you're thinking about the levers of power for vaccine policy.
I think the walls of Congress are penetrated by the voices of their constituents. And I think that as we are able to bring on board more of their constituents and convince them that it's important to let their legislators know what is happening and what their concerns are, the better off we're going to be. Now, in my experience working with Congress on some issues within the military, I have found that Congress is very much plagued by that attitude of a very limited horizon. An election in 2 years or an election in 6 years. And their scope is very, very narrow. So it's difficult to make a point with them on something that is really not on today's front page. And I think that's got to change. I think that we somehow need to see more people who are acting as statesmen rather than politicians when they walk into the halls of Congress. And that's a problem that I don't have a solution to, but I think that we certainly can work with the constituents and let them know how important it is to let their legislators know the programs that are benefiting them and how important they are to them.
And I guess with that, we're going to have to wrap things up slowly here. I want to thank all of you so much for being here and for your insights and for more than anything, the work that you do on this issue, which is so important. And with that, I'm going to hand it back over to Charlotte for some closing thoughts here.
On behalf of the Vaccine Education Center, I do want to thank everyone for joining us for this important and timely discussion. You heard how the events that were talked about in the film directly relate to what we're all dealing with each and every day. I'd particularly like to thank Maiken for moderating today's conversation and rolling with us through our technical difficulties, as well as all of our panelists for both contributing to the film as well as participating in today's discussion. You can find the film Forgetting to Remember immediately available now at hillimanfilm.com. There's a link right on the homepage that will take you to a page that not only has the film, but also some background information about the history of adenovirus. We'll also, as I mentioned, have a recording of today's discussion posted in the coming days. If you do have questions, and we did have some people wonder about showing the film at events, please do reach out to us because our films, even the Hilliman film that was mentioned earlier, are all available for use at local events. And they're a great way to start conversations with your local community. Likewise, if you come upon questions related to vaccine topics that are in the news or things that you're not finding that you're looking for, please don't hesitate to contact us at vacinfo@chop.edu or visit our website at vaccine.chop.edu. Again, thank you all for joining us today, and we hope you have a great rest of your afternoon.